Good afternoon, everyone. My name is Sharon Pollack, and I am an Escalate TA coach. And it is my pleasure to introduce today's speaker for this really important topic. So our speaker today is Deb Bourne. Deb obtained her master's degree in social work at Columbia University and her medical training at Brown University and UCSF. As both a social worker and a physician, she's worked with highly marginalized communities, including homeless persons, drug users, psychiatric patients, and incarcerated and recently released individuals. Deb is very interested in how research can inform and assist with community-based clinical work. HIV prevention is one of her personal and professional passions. And with that, I will turn the session over to Deb.
Thank you, everyone. And thanks all of you that have joined and taken time out of your day to investigate this topic, which is the intersection of HIV and homelessness with some spattering of behavioral health. I want to tell you a little bit about me, and then I'd love to hear a little more about you. We're really going to be focusing on understanding the impact of homelessness and behavioral health on people living with HIV. That's the goal. Right now, currently, I work in San Francisco. I oversee health policy for people experiencing homelessness in vulnerable populations. My clinical work is I'm an HIV and an addiction specialist, but I do all my work on the street. So I work with integrated teams, behavioral health and homeless outreach, case managers with syringe access programs and nonprofits to care for people who are living on the street or use the street as a place of getting resources. So I'm delighted to talk about that. I would love to hear where you're from. So if you could take a moment to put in the chat your name and which agency you're from, if you could, the role, and any questions you have. This is another slide. If this is about using drugs, but it's actually, that's my error, that should say about experiencing homelessness. Okay, I'm going to move forward, and please feel free to put your information in the chat. So what we're going to cover today is actually a lot of data. The reason why we're starting with this is because understanding what the extent of the issue and what is the issue around experiencing homelessness is really important. Some of the stigma challenges of this population and applying how we think about stigma in general and applying it to homelessness, and some policies that you can that's been shown to improve health outcomes for people experiencing homelessness. Some of it, actually, I have to say modestly, is my own research, which I'm delighted to share. I'm going to start first with a moment to just center. And what I do know is that talking about homelessness and talking about some public mental health is very challenging. Many of us live in communities where we see tents, where people are living on the street. It is heartbreaking, but to address this issue comes with both science, but also with compassion. So I'm going to first give you an overview of the definition. And the reason why this is important for everyone to understand, whether you're a direct service provider or work in a public health system like I do, is that the definition of homelessness and how organizations on the federal level consider someone experiencing homelessness impacts funding and the scope of care. So HUD, which is Housing and Urban Development, that funds the continuum of care, which is funding in your jurisdiction for people experiencing homelessness, defines homelessness as living in either a private or public shelter, or living somewhere that was not meant for human habitation, whether that was squatting in an abandoned building, a car, and a camping ground, and an airport, train station. So that's HUD's definition. And how they count this, and some of the data I'm going to show you, is something called the point in time count, which is one night every 2 years, volunteers go out in your community. It usually happens in January. Some places did it in February this year. And human beings overnight are counted if they're outside sleeping in a street. People are not to be asked. It's just if they look like they're sleeping or homeless. You can imagine the standard deviation and the inexactness, but it is how we do it across the country. It's how we get our data. So for health systems, and whether you work for Department of Public Health and Population Health, or you work as an FQHC or in a health system, the Health and Human Services defines homelessness as not just literally homeless by the HUD definition, but also when someone is exiting incarceration, exiting treatment, whether that's residential or hospital treatment, not necessarily when they're in treatment. Supportive housing is interesting. That's housing that has wraparound services for healthcare for the homeless HRSA funding. That only covers the first year after someone's placed in supportive housing and they've signed a lease. This does not, this should also, it does doubling up or couch surfing is another one, and at risk for homelessness. What's not included here, and in San Francisco, we also include is someone living in a single room occupancy or transitional housing where they don't pay or don't have a lease and it's month to month. We consider someone in an SRO without a lease to be in this category. But at risk for homeless is very important, especially for families or for foster age youth that are aging out, and how we think about someone being unstable and under unstable circumstances. Great reference, National Healthcare for the Homeless is a lot of resources, a lot of free trainings, and I encourage all of you to go on those sites to learn about this. And these numbers are usually difficult to count, and because there isn't necessarily a system. And I'm going to get into that in a minute when you'll look at some of the data. So switching gears, and this endinghomelessness.org has a lot of data on their site. This is based on the point in time count, literally homeless as per someone's counted. And we do know from those imperfect methods that we have an increase in total homelessness that we've been seeing. And many places didn't get to do their point in time count since the pandemic. And this year we just are getting data rolling in, but we're still seeing an increase in total homelessness. When we talk about people experiencing homelessness, being unsheltered is an important category and is correlated with worse HIV outcomes. These are actual tents of individuals that were part of our clinical mobile outreach team. Fortunately, I think there's 3 tents here. They had 4 people living with HIV. 2 of them have passed away. One person that was in this red tent here passed away from an overdose after the encampment was cleared. He was just a meth user. There was fentanyl in there, and they took all the Narcan after they cleared the tents, and no one had any Narcan to reverse his overdose. But these are individuals that are living in a tent that are literally unsheltered. And that's one category. Very important to understand in terms of health outcomes. And then there's sheltered. This top left is a picture of MSC South, one of our larger drop-in centers and shelters. They often look like what looks in the bottom left-hand corner, open congregate spacing. There are a lot of shelters that are closed congregate, meaning that there's individual rooms that individuals have, but an open congregate shelter looks like this. On the top right, some locations have been getting tiny homes, still considered sheltered homeless. It's not a legal address. And the bottom right-hand corner is a picture of our safe sleep site that we created during COVID so that people that were living in tents who didn't have enough shelter could safely have resources and shelter in place. A bit of controversy whether those are helpful or not helpful, but we had success in terms of our COVID numbers with this intervention. Still considered sheltered if they're in this location, which is confusing because it's a tent. So, looking at the numbers by state, and you can go on this website to look at your own state. This was based in 2000 and I think in 19. The total numbers, it's a little blurry, and I do apologize, but the darker numbers are higher. So, I'm looking, for example, at California that has the highest number. Um, and just take a look at what your state's number is if you can, or what color it is. And I'm going to show you the next slide is what we got in 2021 from HUD, is who is sheltered. Remember what the sheltered categories are. And just in California, you can see the number is much, much, much lower than the overall homeless numbers. So who's sheltered and who's not sheltered in your jurisdiction is important to understand and know in terms of the population health risks. One of the things that's been happening is that across the nation, we've seen an increase in unsheltered homelessness. Uh, and people that are individuals that aren't living with families, it's been especially high. So the outcomes are worse around HIV for people that are unsheltered. We know that. So the other thing I will encourage you, and this is going to get updated with your count, is to have an understanding about how your state and how your system is doing in terms of sheltered versus not sheltered. In the top left, you can see California has one of the highest rates of unsheltered homeless. Huge issue for COVID, also huge issue for other public health issues in our rates of HIV, Hep C, and hepatitis A. Um, so out of our very large homeless population, you can see that the majority of people are unsheltered. Whereas in Massachusetts, where the right to shelter is one of their legal mandates, it's a much lower percentage that are unsheltered. So sheltered, unsheltered, and what proportion, something important to think about. So what triggers homelessness? And what's not on here is really this is a state and economic issue. Um, we do know that in general, of the people experiencing homelessness across the nation, about 25% have a mental health diagnosis that usually predated, but that many people, just like many people with chronic disease, many people in a chronic stress situation will develop depression, anxiety, and other forms of reactive diagnosable mental health because of the stress and the trauma of the situation. So the numbers are probably greater. This is people that have a diagnosable mental health illness. But really, the hugest drivers of what's triggering individuals, and many of the pit counts, the questions are asked, point in time counts, are really related to loss of job, rent, family conflict. And so, and as opposed to individual issues such as a substance use addiction. But really, issues of safety are huge, and there's also medical. Um, so usually what people report nationally. Going to give you an idea from our last point in time count in San Francisco, 2015, 17, and 19. If you look at the 2019 column, loss of a job accounted for 26% of the people that were interviewed as a small cohort of our overall people experiencing homelessness. And that mental health and drug use accounts for around another 25%. But they're not the only drivers. So the assumption that everyone experiencing homelessness has a substance use, addiction, drug use, or mental health issue is incorrect. But it's huge. So HIV prevalence is very important to understand in your area. When I started working in San Francisco in 2006, it was something like 8% of the people experiencing homelessness had a diagnosis of HIV. Nationally, and this is from 2009, but the numbers unfortunately have not changed. 1% of the general population in the United States lives with HIV. Interestingly, 1% of the general population of the United States lives with diagnosed schizophrenia. And just a little fact, about 3 to 5% of people experiencing homelessness are living with HIV. So you can see that a larger proportion than the general public in this particular population. And it's really important to understand and know um, in your area. These are who are reported. This is again HUD definition, point in time, either sheltered or unsheltered, not including doubled up. So what we know about homelessness is both a cause and an effect of HIV infection. People coping with homelessness are at a greater risk of becoming infected with HIV, given the conditions and how people are forced to live. Many people, even that are doubling up, going bed to bed, or are in complicated uh, um, conflicts. People living with HIV/AIDS experiencing high rates of housing loss and instability. And I'm going to show you a little bit more about this second.
Deb, I just want to
So,
call attention to a message in the chat, a question. What was the study's
family
definition of
conflict. Yes,
family
yeah. So,
conflict?
first of all, it's not a study. This is from the HUD definition, a federal definition of family conflict. And I don't have that. I have to look at the HUD, but it says defined by this federal group. So, and I believe my understanding when people are trained that it's self-report that it was a conflict. You know, my aunt kicked me out of the house. My mother kicked me out of the house. There was some conflict between the individual that led to the person. But I would have to go look at the HUD definition. So it's not a study. It's a HUD. Does that make sense? It's part of the point in time count, and people are given questions that they have to ask. And so what they do to get this data is they go out and do the count, and then each community either contracts or hires individuals to interview a small percentage of people experiencing homelessness, and they extrapolate from there. I hope that answers the question. So it's technically not a quote study. It's like a census survey almost. I hope that was helpful, Jimmy. Okay, thanks. People living, I love these questions, by the way. People living, I was going to wait to answer that when I went forward to Sharon. So I did see it. And if more questions come up, I'll answer it if it's specifically relevant. I'll wait a minute. So people living with HIV and AIDS who are experiencing homelessness or unstably housed are more likely to enter HIV care late. We know that with many health issues, HIV is not alone. I was also did a recent study that people entering for termination also enter late to care. And I'm going to go over a little bit about why we think this happens. They have lower CD4 counts in general and higher viral loads on average in most communities. Are less likely to receive and adhere to retroviral therapies. This does not mean that someone can't take it, HIV meds, and be undetectable. I'm going to talk to you all about that. But it's just without the right intervention, this is what we see. Of course, the right intervention being housing, but even without that, there's things we can do. They're more likely to be hospitalized and use the emergency room in general. People experiencing homelessness with HIV experience higher rates of premature death. And the housing status, really what we know has more impact on health outcomes than any other demographic, like drug use, alcohol, or even receipts of social service. So housing alone is one of the number one health interventions we can do to help people get stably housed. So in the fiscal year 2019, the National AIDS Housing resources are great, where there's a lot of information. Many of your agencies have HOPWA funding, that over almost 400,000 people in the US with HIV are going to need, living with HIV, are going to need some kind of housing assistance almost yearly. That's a huge number. And the number of households with someone that's living with HIV that lacks stable housing adds another 140 to sometimes I've seen this number even higher some years. The number of households being served by HOPWA which is a great program, is low compared to the need. You can see that it's 56, and really we need more services to be able to address the issue. So how do we start the conversation to understand someone's housing status? And again, I'm going to encourage all of us to think about it as a housing status. It's not who someone is. They're not homeless. They're experiencing homelessness. It's a status. It's not their definition. And we're trying with all the work with Stigma to not to help people be defined by these conditions. Just like you're living with HIV, you're not HIV. So to do this, I'm going to invite all of you in the middle of the presentation to join me to focusing a bit on this Thich Nhat Hanh quote. It's actually outside of his center at Plum Village in France, that I have arrived and I am home. So if you wouldn't mind joining me for just a moment to put your feet on the ground and to bring your intention and your resourced self, because we're all very lucky that we're here. We're someplace where we're safe, that we could watch and be engaged in this conversation, where we're learning and we're safe. And so we can turn our intention, and you can close your eyes or just lower your gaze back to the home within yourself. And a lot of the work and the training I do around stigma is helping all of us feel safe within this home, within ourselves. Just noticing where you're sitting. You can notice your breath, or you, whatever feels safe. You can notice your feet, whatever you want to focus on. And paying attention to how it feels to be home within you. That you are a world within yourself and you're safe right now. And when you're ready, you can raise your gaze, take a look at me, look at the screen, and feel how that feels inside, how your nervous system feels. Now, imagine that you're someone that doesn't have a place to sleep, whether you're sleeping on a couch or sleeping outside, and you go to a health center, they ask you your name and then your address, how that feels. Just check in with yourself. And just like with our understanding with SOGI data, and I work with transitional age youth and a lot of homeless youth, how you want to be identified is really important in how we look at stigma. But for the number of people that are experiencing homelessness or unstably housed, asking them their address can be very triggering, and often we don't get the right data. If you look at the numbers and you think about your organizations, how many people are listed as experiencing homelessness or unstably housed? I'm sure you're in your jurisdictions. So just checking in how that might feel. So the first thing is we should not be asking people, "Are you homeless?" Right? It's first of all, it's not. It's very stigmatizing, and we're not going to get the right information because a lot of people don't consider themselves experiencing homelessness. So, what are some ways that we can get to that information? So, just like what name would you like to be called, even though the form says name, right? So, it might say name, but we teach our eligibility workers or the people filling out the form, what name would you like to be called, right? And we're changing our electronic records and other forms. There's ways that we can ask about instead of address. Do you have a regular place where you get your mail? Do you sleep there? And if not, where do you sleep most nights? Where did you sleep last night? And using that and the address, very easy. That's what we do with our eligibility workers in our city. I ask people when I'm working with them on the street, because not everyone is, where'd you sleep last night? Because I want to know where they're going to put their pills, where they're going to, do you feel safe? Is it a regular place? Where is it? But I'm on the street doing my work. The VA screening questions are great. And they look in the last 2 months if people have been living in a stable housing, that they own, rent, or stay as part of housing. This is one of their intake questions. No means that they're positive for housing instability. If people are worried or concerned in the last 2 months, also positive. So these are great questions to get to that housing status. Remember one time when I called 911 for people fighting in the street when I first moved to San Francisco, and the person on the dispatch said, "Are they homeless?" I said, "I don't know. I didn't ask their housing status." So this is questions getting to housing status, not just by how someone looks and what your assumption is. So what does housing stability and HIV care, and what can we do to intervene? And understanding Maslow's hierarchy of need, I usually ground myself in this, in that all of us as humans need air, water, food, shelter, sleep, clothing, sometimes the biological need of reproduction, but these are physiological needs. And when they're not met, we're really, a lot of our focus goes to this particular need. When we're not feeling safe, the next focus goes there, just what our physiology does, and then to love, esteem, and self actualization. I'm fortunate enough that I have safety and belonging, and that I work on my consciousness with my mindfulness program. But I have the red, orange, and green in my life. So when you're working with individuals that don't have issues on the red, and we're talking specifically about a place to sleep that's safe, their energy is going to be going to that. That does not mean they don't care about their health. It's just how much work or expenditure can go. So we have to up our game of how we do our work. This is both for HIV prevention and for HIV disease management. So really, it's all about the brain and understanding this imperative of your brain and your being, and the level of interventions that we offer to help folks living with HIV and to prevent HIV. Because someone's ability to adhere requires that they have time and energy to address it, doesn't mean that their inability to hear is a character flaw. So we're not saying this person is non-compliant as a judgment. We're saying that they cannot adhere to even what they might want for their care because of their competing priorities in their life, and that we need to actually support them. Just like if someone had a broken leg, you wouldn't expect them to be able to walk without crutches. We're not judging them for having a broken leg. We understand that that's the nature of what they're going through. So when someone is traumatized, just like you might have been in that experience of, I asked you your address after you felt really zen, you're not going to be able to concentrate as well, sit still, listen, set goals, be physical, and talk. That's the nature of trauma. So when people are out in the street, and not only they're thinking about where they're going to get food or clothing, or be safe, they also can't follow through, and they're not able to be their best selves biologically. So, with that in mind, I usually show this picture and ask people the top question, which is, and you can put it in the chat, is this a good location for a health center for people with lung disease on oxygen? So, would you put a health center on the top of the mountain? Yes or no? You can put in the chat. Um, and the answer is no, that would be crazy. That person couldn't breathe, they wouldn't be comfortable. This is not the place to build it. And understanding that is part of the thing that I want all of us to take back with us, that four walls health centers are not acceptable for people who have behavioral health issues or experiencing homelessness and have really experienced a lot of medical and sanctuary trauma, because they have not been able to adhere to the kind of programs and facilities that we've created. And understanding that one size fits all really is not trauma informed and increases stigma because people feel bad about what they can do. So, one way to understand this is primary care, not just for people that are living with HIV, but are at risk for being infected with HIV, is that having different kinds of primary care to meet where that person's at. Down the bottom, thinking about routine primary care, those are FQHCs, but healthcare for the homeless programs. And if you are not working with your healthcare for the homeless program, the one thing to do, write on a piece of paper right now, find out where the healthcare for the homeless programs are in my community, and I'm going to partner with them. But if you are an HIV Ryan White program or you support HIV Ryan White programs, it doesn't mean that you cannot take on some of the best practices of healthcare for the homeless. And one of the programs, Positive Ward 86, Positive Health in San Francisco, that's very famous, program has started taking on healthcare for the homeless models of open access in their health center. So anyone who's experiencing homelessness can come walk in the afternoon. They're always welcome. Where I work is in the Brown area of community programs. So in a social service agency, people can come in every morning for breakfast. We actually dispense medication from there, and I'm going to go over that in a minute. But my clinic is actually embedded in their morning breakfast program. The other place where I've actually personally worked is in methadone programs and mental health programs where individuals are at high risk for contracting HIV, but many people are living with HIV, and we have medical care centers with those mental health programs. And the last is mobile care, very costly, but is something that we have targeted in the state of California with Cali, something that's going to be getting reimbursed. We also have programs on the left where the red, where our urgent care center, street medicine, our STI testing clinics all have treatment for people who test positive for HIV that they can go and have some bridge care until they get into routine primary care. In the clouds is always understanding that everyone wants something for their health. Maybe they're pre-engagement to a health center, but they might want something, and maybe they don't want to take any medicine. They're just going to keep things as is, but are really palliative care. So policies that do improve outcomes for people experiencing homelessness, besides getting people housed, is having open access clinics and no late policy. Because someone comes late, often is because of transportation. And so holding people accountable that have other priorities and needs to a late policy in a strict clinic is not helpful. Um, the next is transportation support, and this is not just for people experiencing homelessness, but for many communities. It's a huge issue, especially rural communities, but having tokens and reimbursements for buses in urban centers. We do a lot of work with MediSets and med adherence support. Many people experiencing homelessness have challenges with pharmacies. Many people living with mental health and substance use issues also have challenges with pharmacies. So incorporating and having places for people to pick up their meds, whether in a med locker, at a food pantry, or at a syringe site, or to come into like the program where I work, where people can come pick up their MediSet that we have in a bag. The pharmacy delivers to us and we just hand them the bag. Having incentives like food, clothing, or gift cards to achieve the person's health goals. So if someone wants to take HIV meds, once they're undetectable, you can give them a gift card, blood work, etc. It's something called contingency management, works very well. In-clinic housing support, so having partnerships. We have our housing assessment team from one of our nonprofits that does all the assessments with our continuum of care actually comes to the drop-in clinic once a week to do health assessments. And so having those partnerships alive. Peer navigation, I can't say enough about how important it is to have navigation of any kind, but peer-to-peer is where it's at, and helping people get from point A to point B with support. Mobile teams, many of your nurses will love this. I can't tell you how much our nurses love this. Part of our nurse adherence program is done through reimbursable through Ryan White, and it's a health home program where health workers go or either call the person or drop off a donut to remind them to take a med every day. For our sicker folks, very similar to what TB does for TB treatment in many of your jurisdictions. So they might be a good partner to talk about how their programs work for their TB adherence. And then creative communication. We gave out throwaway phones, helping people get Obama phones. Our Homeless Youth Alliance does all of their communication via Facebook. So they have their own page. And just like many jurisdictions from many communities are actually helping people sign up for HIV testing, syphilis testing, et cetera, online. People experiencing homelessness do go to the library, they borrow someone's stuff, and people do a lot of communication on Facebook. Also, with our program and our mobile program, we had bracelets that had our name, our location of our drop-in centers. So even if we were seeing people on the street, the number of their case manager, and then we'd write in a Sharpie if they had an appointment or something, so that they wouldn't, even if their stuff got stolen or something, they would have it on their person and didn't have to carry a card or a business card. So having your information on bracelets is really helpful. Some things we did for HIV, our HIV homeless outreach and mobile engagement was a SPINS program, a special project of national significance that HRSA is still using, and we're sharing this across the nation because it was so successful. It's a completely mobile program. The original study was done for people that were the hardest to reach with living with HIV, experiencing homelessness and mental health challenges in San Francisco. Some of the things we did, you can do in your with any of your programs, is to make and ensure that you have an interdisciplinary consumer-led program. So we took all of the programs, the Committee of the Willing, that were already working with this population and got them together and asked them, how would you make a program? That included our homeless outreach team, our disease investigator linkage folks, our street medicine team, and some nonprofits, and got together and decided to make a team that had someone from each of those different agencies. It included a peer, a nurse, a provider, um, a peer navigator, and a social worker. So the care is based on the consumer's health. One of my patients, who's now housed, had not been in care for a year, came into clinic. They know that I'm always there on Friday, can open access, can walk in. And I said, you know, it's so thank you for coming. I'm so grateful. And if you don't want to take meds, it's okay. And he took a sigh of relief. I said, I'm not judging you. You're here. You obviously care about your care. Let's start with what you care about and what you're wanting to do. And so really it's based on what someone wants for themselves. The consumers, their captain, their team, that we're just giving love and understanding that when people go to health centers, often they're asked, and the number one question is, do you want to take HIV meds and let me give them to you now? And if they're not ready for them, or they don't want to say, I'm afraid someone's going to take them or I'm going to steal them, no, or they come back and like, I didn't take my meds, and they don't want to talk about why, um, often creates more stigma. So we focus on what people's skills are. And the picture here is a woman that was one of the city's highest users. In 6 months, she was hospitalized, I think, 20 times. And she had on, she's the yellow bracelet from the hospital, a pink bracelet, which was our home bracelet, and a bracelet that I made for her was something I was wearing that I made for myself, and she loved it. And the woman literally did not lose that bracelet through 20 hospitalizations. It was amazing. And every time I would go to see her, she always had the bracelet on. And she knew what she cared about. She was amazing keeping this on her. So really, how do I get that strength that there's things that she cares about? And she loved feeling like a woman. We used to go and paint her nails. That was a picture after we painted her nails. She loved feeling like a woman no matter what. And that was something important to her. So we would go and paint her nails when she got hospitalized. And also humor and bringing chocolate, coming to a gift. When you visit someone out in the street where I do my work in a tent, I understand it's their home, it's their being. And just like if I went to your house and you invited me over, I would bring a gift. I usually come bringing gifts. So this is a picture of our nurse taking blood for someone on the street. This woman was deaf and mute, and actually got housed and undetectable before she went inside, because we would go and find her where she would hang out and gave her her pills every day. um, we also now are using injectable meds in some of our drop-in sites. Um, and this is another one of our amazing case managers looking for a client. But we do all of the services around the street. Even if you just had case management or nursing go out to the street to start to engage people, it was a huge win. You don't need a whole big team. Anytime someone got into a transitional location in our cohort, we would go there, whether it was jail or hospital. We'd help them follow up and navigate those systems. Contingency management, which is giving people incentives for their health goals. Um, Harm reduction, palliative care, end of life. We had a lot of people who did not want to get work, did not want to take meds, and we really just ended up supporting them. We did a lot of pregnancy care and pregnant people on the street as well, and just getting creative when you have an interdisciplinary, amazing team of public health folks. And this was all supported by our health policy to see how to actually do this kind of care. So just quickly, I'm going to go through some of the results. This was from 2017, and our data has changed, but this was after the study. You're going to see a red bar and a yellow bar. The reason why there were more people, less people that were in the study, the total people that we worked on was different, was because about 45 people that we worked with in the course of the 2 years were so psychotic they couldn't even answer questions to be part of the survey. So someone had to be able to do the research within 2 weeks of us engaging with them, and people were so psychotic um, they were not able to answer the questions, but we still worked with them anyhow. And you can see that we housed in the study about 83%, but 79% of the folks in the study achieved viral suppression. Many of them were virally suppressed prior to going inside. The deceased number, unfortunately, is much higher. What is very interesting and heartbreaking, that I thought the hardest to serve in this cohort would be folks that were very psychotic on methamphetamine. Um, and really, the groups that didn't achieve viral suppression and had a very challenging time going inside were women who had lost custody of their children. And 90% of women who live on the street in San Francisco have lost custody of their children. So the shame and the stigma around this was so huge. And people who had once been in the workforce and had recently lost their job within 5 or 6 years of the time that we met them. So this is something that we call shame-osis as opposed to psychosis. And the shame factor, though we used injectable medication for people that were psychotic to help them get stabilized from their hallucinations or their delusions or whatever was impacting their ability to follow through on their health goals, it was very challenging to find anything to address the issues of shame that these two populations were challenged by. So some things I call a spin off from our spins grant is that work we're doing now, and it was a basis of most of our COVID work, which was to go out to encampments with multi teams that do testing and syringe exchange, overdose prevention, HIV, Hep C, and syphilis testing, and to go out and bring in care to communities where we were seeing outbreaks of either HIV, Hep C, or Hep A. Even we were went out there. So this was a huge driver for how we actually ended up doing the work with HIV, with COVID, and many people in this picture actually were leaders in COVID as well. Um, we had 7 people in the whole that experiencing homelessness that died of COVID um, in our community. Um, we brought buprenorphine, Suboxone, HIV rapid testing and PrEP to the street, family planning, did testing, and also immunizations, and COVID is one of them, and we're continuing with this best practice model now. The other thing that I will also encourage everyone to do when working with people experiencing homelessness and living with HIV is to partner with your emergency room. It's a picture of me with a program that we also started after the HIV program called Social Medicine. Um, it was so many times we'd go into the ED looking for our working with our clients, and people are like, "How do you work with these folks? Help and coach us." And we ended up partnering. We had a very strong um, HIV response already for anyone that was tested positive in our ED, and we added the work that we knew as healthcare for the homeless providers to support this effort. So it was a very successful model. And lastly, I just want to leave all of us with the most important cure for homelessness, which is housing. And being housed and being stably housed improves health outcomes. This important indicator that we all need to know about our communities and understand the stigma that affects this population, both in us getting the information about our housing numbers and knowing that we need to change the model for how we do the work to help improve health. So there's a lot of resources here, healthcare for the homeless being my number one, lots about trauma informed that will be going out to you, and some great articles and information about where you can get data about in your community. One of my favorite quotes, and I want to leave some time for questions. So thank you, everyone. So our great folks. We have a small group. You don't have to come on camera. I think it's just a handful of us for this conversation. And there's other people that are going to watch this later. Oh, thank you for coming, Becca. I'll see you soon. Um, if you could, there's a question. Okay, family conflict. If there's other questions, you can either put in the chat or please just feel free to speak out. And Sharon can help as well.
Don't see any new questions, Deb. But I just want to put it out to the group. If there are situations that have been challenging in your programs, either with regards to staff um, or clients, as it relates to homelessness, feel free to bring them up, and Deb maybe can weigh in on them. And there is one question in the chat.
Oh, thank you, Becca. You're still here. I thought you were leaving. Yeah, so people young, this is a really important question. Actually, before we got on, Sharon was asking me what groups are really high risk for experiencing homelessness. And I was saying youth that come out of the foster care and transitional age youth. Have a very, very high risk of becoming experiencing homelessness. Many are unstably housed, even in the situation that we put them in. And we do have special housing in San Francisco for people under the age of 25. That's not always filled. So many of those youth, we were actually able to get them inside immediately, and they were our priority population. But who we actually focused on, Becca, for this because we didn't have many resources once people turned 25. So we have, at least in San Francisco, a lot of resources for transitional age youth 18 to 24 living with HIV. We have nothing once they're 25, and many of these programs actually have to ask the youth to leave. So their case managers that they worked with, the clinics that they worked with, and it's heartbreaking to see. And many of the folks that we worked with in the study actually had been a youth in these programs. So we prioritize youth that were aging out. And we do see, unfortunately, people living with HIV. Sarah, when you look at your HUD report for your area, when your point in time comes, there will be a section about transitional age youth, so you can look at that data. It also will have data about the number of youth in your children that are experiencing homelessness in your jurisdiction. So, for example, in San Francisco, our report right now is 2,500. I think children that are in the health system that families are experiencing homelessness. So it's really important to look at that data and, um, you know, your jurisdiction of people experiencing homelessness, just put in your head at least 3% of those folks are living with HIV. And in San Francisco, as I said, our numbers are a little higher. I hope that answers your question, Becca. Rapid test on-site to our youth clinic. So this is what Becca, can I read your question, Becca, or do you want to read your question? You can speak out.
I think she said that you can read it.
Okay. Okay. We provide rapid testing and treatment on site at our youth clinic. However, we barely have anyone asking to be tested. How do you get people interested in getting tested? Gift cards, socks, we offer incentives. So when we go out in encampments and with our youth, people get paid. I remember as a resident, so there was something called the UFO study, which was for testing for youth. That San Francisco has had for like 25 years. And I got a needle stick from someone as a resident 22 years ago, and they knew all of their status. They had a card and was a great way to get people tested. So many of our youth in San Francisco, because we had this huge UCSF study that has been going on for 25 years testing, and incentives are the number one. The number two is having their friends and having peers do the outreach. And so not just doing testing in your clinic, but actually going to where they're hanging out and hiring other peers to do the outreach to get the youth in. Becca is really the other way that we've been doing and then support with prep. Oh no, we love your questions, Becca. Thank you again. if there's any other questions.
Yeah, this is Jimmy in Arizona. I have a question for you. Um, have you ever faced any political backlash? And when I say political, I mean where the views of the folks that are in positions of leadership just do not align with, that of giving homeless, folks experiencing homelessness a hand up. Because I know here in Arizona, obviously, politics, play a part of it. Same thing we face with like SSP programs, where it's just the one side is just not going to budge, and they're like, "This is what we're offering. This is all we're offering. Don't you dare do anything above and beyond." So, I
Um,
mean, we did overcome a recent hurdle. We overcame a recent hurdle where even within our own Ryan White program, where homeless folks were not being automatically assigned a case manager because we had folks in position there thinking, literally saying, well, just because you're homeless doesn't mean you're incapable of providing for yourself and you don't automatically need a case manager. Now, we did overcome that insane logic to where now folks that are experiencing homelessness automatically get a case manager so they have someone to talk to and to partner with. But that's the kind of politics we have to deal with some of our stuff here, on top of the stuff from like the state capitol and things like that.
you broke out at the end, Jimmy. It could have been mine. Thank you for that question. I think this is the question with everything in the work that we do. First of all, how do we care for ourselves within politics? And my life is politics. I'm often in the doghouse. This is what I do, health policy. That's why I'm actually having some fun times talking with you to get away from my day to day. It could be stressful. It's part of my self care. And so, how do we care for ourselves in those situations? Because people need us to be grounded. This is the work of Stigma. It's to care for ourselves, our oxygen mask first. Um, and syringe exchange. I started my career 30 something years ago working with ACT UP, running away from the police with needles in my pocket, trying to get needle exchange legal in New York. So I still see myself as that person, as all of you are. And so we need to just up level the public health things of what we know are facts. And so really it comes down to biology and public health, and it's one of the powers we have as public health leaders. We've actually seen this in COVID, though, still people have controversy with science in COVID, but there's some facts. And so, I actually believe that anyone living with HIV should get a case manager or a navigator, and it should be an opt-out regardless. And if you have one or two other issues, 100%. So if you think about people living with cancer, there is no judgment about them getting a care navigator. Anyone with insurance that goes to any of the famous big cancer centers is offered a cancer navigator. So it should not be any different for the folks that we're working with the stigmatizing illness of HIV, and then many other, they also have other challenges, in this case, homelessness or substance use. So I think looking at best practices of what we do with other disease and with other diseases that don't have stigma, and using that, Jimmy, if that's helpful. I'm so glad that you're keeping on focusing on this. People experiencing homelessness, not everyone needs as intensive a case manager, but people, just like we know with any kind of chronic illness, need navigation. Our systems are very, very complicated. And most people experiencing homelessness don't do well in just a regular four walls clinic because of how complicated our internal systems are. So even if you have an internal navigator or peer navigator or something, I applaud it. As a clinician, I have said this in my other presentations to you all, I actually don't see patients by myself, hardly ever. The folks that I work with have so much trauma that, as nice as I am and as much candy as I might bring, people still need to have another individual with them in order to feel safe. So it's understanding the amount of trauma that individuals are having, and that Maslow's hierarchy, Jimmy, that I was showing you before, that they have a lot of things to juggle. And if we want them to include HIV, we need to make sure that we're helping them with juggling. And doesn't mean that people aren't resourced. Like that woman I was showing you with the bracelet, your folks might have skill sets, but they need case management. So, and then I would love to talk to any of your leaders that need a person. It's the only time I like people to call me doctor, because typically I don't, but I'm like, the doctor says, that this is the right medicine is to give people case management. It is an intervention for medicine. You wouldn't be prescribing the wrong medicine, and case management and housing are interventions that improve health outcomes. So thank you, Jimmy. I hope that helped.
It did, and I'm waiting for your when I get your slides, I'll definitely keep your contact information and call you as a resource when I'm trying to pound some common sense into these people's heads, because sometimes it's not easy.
It's not. I've been doing a lot of self-care with all that's going on in our nation right now. We're dealing with public health and issues that I never thought we would return to. So it means even more we must stay grounded and alchemize our shame and trauma within our own selves into love and power, and help the people we're serving do the same. Even more important for us to care for ourselves.
Are there any other questions for Deb?
Thank you, everyone, for your time. I know that people's schedules are busy. Please spread the word about looking at, if you leave with one thing, how we actually ask people their address, and think about that and how you're asking that in your health centers or in your jurisdictions. If you work for a health system, one of the things we're looking at is that how we report to the CDC, any of our data, they don't ask about housing status. So we need to really start to get better systems for that. So let's push this out, that we're including this in everything that we do.
Great. Thanks so much to Deb for leading this session, and for you all for joining and engaging in this discussion. We'll see you at the next office hours.